Charles Unit at the University of York. This is the Research Room. Hello.
Hello.
And welcome back to another episode of the Research Room with me, Lucy Ather.
And me, Janine Healy.
And today we are joined in the Research Room by two researchers who are going to tell us all about their project, BioDrive. We have Professor David Allsup joining us and Lydia Flett. Welcome to the Research Room.
Oh, thank you for having us.
Thank you.
You're very welcome. So, could you just introduce yourselves for our listeners?
So I am Lydia. I'm one of the trial managers at York Trials Unit, and I have been working on BioDrive since it's a few years now. I think 2020.
Oh wow, yeah, long time,
but not as long as David.
Oh,
So I'm David Allsup. I'm a professor of haematology at the Hull York Medical School and the University of Hull, and I'm also a haematology consultant at the Hull hospitals. And so Lydia and I have been working together, as I say, on BioDrive since 2020.
Oh, wow, yeah, long time.
Mm.
Oh, well, thank you so much for joining us in the Research Room. So, just to kick us off, could you tell us the name of your project, the kind of full name?
So it's the BioDrive AFS study, and it's a randomized study looking at the best way to prevent and treat infections in people with blood cancers.
Okay, right. So BioDrive. Does BioDrive stand for something, or is it just BioDrive?
Yeah, it does.
They always have a longer name.
It's a biomarker-driven antifungal stewardship in acute leukemia. So yeah, we sort of took some of those letters and made the acronym.
And made the acronym.
Made the name, yeah. Because we have like a little competition about the name, the acronym.
We do.
Yeah, we do. Yeah, we like to compare everybody's. And, so, how did you get the name then, BioDrive? So you picked the letters from everywhere.
I suspect we typed it into a thing on the internet
Yeah.
and then see what's up, and then
AI
ignored the rude ones, and then
Yeah. Oh, that's a shame.
Yeah, this was before my time, but yeah, it's probably something along those lines.
Yeah. What do you think? BioDrive.
I don't know, because it bears nothing to the.
What does it make you think of? Makes me think of race cars.
Yeah, it does
What do you
make
think of race. I guess
cars,
driving that.
driving a car
makes sense.
and a biological car.
Yeah.
Yeah, is that what it's about?
driving biology forward. Yes.
Oh, I love it.
Oh, that's
there we
quick
go.
thinking. Yeah,
It all fits. Okay, right. Well, we're going to rate your acronym then. What are you going to give it out of 10?
No. You ask me every time, so you've got to do it.
Oh, no, because I normally just see what you say, then I can be a bit nicer.
Yes.
Okay. Oh, out of 10, I'm going to give you a 6. Oh, no, that's quite good.
Is that good, is it?
I think that's quite good.
It's quite
Because,
good.
and I'm only giving you a 6 because BioDrive, it's not a perfect acronym for like one letter per letter.
Yeah. So we
Yeah.
I'm more of a stickler for that, not you. So
That's true. What
yeah.
are you going to give them?
No pressure on now. The problem that happens to me is the people are looking at me,
Yeah.
and then I go
Staring you down,
Yeah.
Janine.
Yeah, to give a low grade. I just can't do it. I'm obviously such a weak woman, you know. I might just be the same as you. I'll go 6, I think. Yeah, but just
Pop
because.
out, but I'll allow it.
Yeah, it's because I'm a little bit. I'm a right stickler for this. It has to be a letter for each of the words.
I'm not sure I'd have come if I thought you were going to give our acronym a kick in, to be honest. But,
I'm sorry.
Is this a bad start to the interview?
yeah, it's possible. I expect it.
Okay, I'll up the grade. It's
Easily bribed.
yeah,
don't
I'm
worry.
afraid so. No. It's a nice word, isn't it? BioDrive. So.
Yeah.
Yeah, we were pleased with it, and the logo for the trial, we a local sixth form college had a little competition, and they all sort of designed logos, and so we picked one of them, and the winner. So the logo came from like a sixth form student. Which
That's nice.
Yeah, we thought that. Yeah,
We were going to include logos, then we realised we're on.
No one can see
Yeah.
it.
Nobody can see them, so it's not very good.
No, I suppose not. Yeah, but it's Beverley High School for
Beverley
your
High
listeners.
Okay.
Shout out to Beverley High School.
Absolutely, yeah.
I like it when they get people involved in these.
It's nice, isn't it? It's much nicer than just kind of putting it in a generator or something. You know?
Yeah.
Yeah,
You
that's
can
right. Yeah.
I'll tell you, we could,
10 out of 10?
we'll put it up.
You might get an extra 0.5 for your nice logo.
I think so. Yeah. So, can you sort of, in a nutshell, describe what your project's about? Because I know it's quite complex.
Yeah, sure. So I'm a haematology doctor, and that means I look after people with blood disorders. And one type of blood disorder is a type of blood cancer called acute leukemia. And people who have acute leukemia are treated with a very intensive treatment called chemotherapy. And often they have to be in hospital for quite long periods of time. And one of the main side effects of this intensive chemotherapy is it weakens people's immune system, so they're at increased risk of infections. And we spend a lot of time worrying about what infections these people may have and how to treat them. And there's lots of different infections people might get. They can get viruses, which is like the common cold, but when your immune system is weak, they can be more serious. You can have an infection with something called a bacteria. And you can also get an infection with something called a fungus. And fungi are things that are everywhere. Fungi are things that make your cheese go blue, and mushrooms are fungi. And normally in your day-to-day life, these problems don't bother you too much. But when you've got a weakened immune system, you can get quite serious infections with fungi. And the problem for people like myself and my colleagues is these are quite hard. It's often quite hard to know if a person who's had chemotherapy, if they have an infection from a fungi or if not, if it's something else. And we spend a lot of time worrying about this. And the result of that is we often give medicines to treat fungal infections. And because we're often not sure whether there's one of these infections present or not, we probably overuse these drugs. And the problem that creates is that these fungi can then become resistant to commonly used medicines. And they also have side effects as well. So people having chemotherapy for leukemia are having a miserable time as it is. Mm-hmm. And if they have to have extra medicines that they may not need, then that can make the situation worse. Yeah. So BioDrive is about trying to see if we can reduce the amount of medicines that are given to treat fungal infections. And what we're doing is within the trial, half the people are treated in the normal way. So they'll often get medicines to prevent fungal infections. And if they become poorly, the doctors will treat them as they would do normally. And the other half you are getting sensitive blood tests called biomarkers. And a biomarker is a test that can say, is an infection there or not? And we're trying to see that by monitoring people with these biomarker blood tests, can we reduce the amount of antifungal medicines they need? Does that then result in people feeling a bit better? Does that reduce the amount of these medicines? Does that reduce the chance of these fungi becoming resistant? And does it reduce the cost of the health service? So that's broadly what it's about.
That's really well explained.
Actually. I know, yeah, you explained that very well.
You should do that, shouldn't you? You are the chief investigator.
Oh, thank you.
From what you've explained,
yeah,
what made you focus on the particular
on that area?
Area, yeah.
So it's something that it's a common problem. So I've been a haematologist for a long time now, and for all my career, we've been struggling with these decisions. Does somebody have one of these serious infections or not? Should we give one of these medicines or not? If we do, how long do we give it for? And the whole area has not really moved on that much in about 30 years, which is the amount of time I've been doing this. And the NHS decided to try and answer some of these questions. So what will happen sometimes is the NHS has a research body called the NIHR, and the NIHR will fund research into common problems. And so the NIHR asked for investigators like Lydia and myself to submit proposals for a research project. So we saw this proposal and thought about it and thought, well, this is a real problem, and it's something that's unsolved, and we should therefore have a go at trying to solve it. And so myself and another doctor called Professor Barlow, who's an infection doctor, working with Lydia and her colleagues, put the trial together.
Mm-hmm. Yeah, and it's basically the problem is, one of the problems, isn't it, is that the antifungals, it's a bit like antibacterial resistance, isn't it?
Yeah, that's right. And it's a growing problem. So these medicines are used to treat fungal infections in people, but they're also widely used, I think in agriculture, they use them a lot.
Farmers are renowned for
using various medicines, yeah. And the problem is infections like fungi and bacteria, they're quite clever. And when they see drugs that are used to treat them, they can sort of develop ways of becoming resistant to them. And the concern is this will sort of continue to happen. So we have to be cleverer about how we use these medicines.
Yeah, you hear about antibiotic resistance quite a lot, but so this is a similar thing, antifungal resistance, which we don't really hear about, but maybe we should.
No, it's an emerging thing, and the NHS is starting to pick up on it, and there's a lot of interest around the world, particularly from infection doctors, and that's sort of then spilling over into specialities like my own.
Yeah.
I suppose it's used a lot, overuse, and using it as a preventative. Is that it, or you're using it if you think they might have an infection?
So both, yeah. So because we worry so much about our patients and we want the best for them, often the patients will get preventative medicines. So they'll get medicines to prevent fungal infections, medicines to prevent other infections, and that can help, but they do have side effects. Right. There's lots of new and really exciting anti-cancer drugs. So the leukemia is cured by chemotherapy, but there's lots of new drugs coming through that improve people's chance of being cured. But the problem is the new anti-cancer medicines often interact with existing things like antifungals. So one will make the other work less well or increase the risk of side effects. And so there's a constant balancing act between drugs that you're giving to treat the cancer and then other medicines for other reasons. And people can be on so many drugs that they interact and then cause a whole new set of problems. So that's the other rationale. We're trying to minimise medicines to only when people need them.
Yeah. So ideally, I suppose you only want to be giving people the antifungals when they definitely have a fungal infection.
Absolutely, yeah. So absolutely. So and it's sometimes very, very difficult to be absolutely certain. And so in BioDrive, we're trying to use these sensitive biomarker blood tests to increase the certainty that we have when people are poorly and we think, well, this person may have a fungal infection. The X-ray looks a bit like it. And trying to work out how to best use these biomarker tests to decide on appropriate treatment.
And so I guess you could tell us, what is a biomarker?
Yeah.
So a biomarker is a very general term. So a biomarker just refers to any test, so it could be a blood test, that helps you understand whether a disease or illness is present. So for instance, many who have prostate cancer, there's a test called the PSA that's often done, and that's a biomarker for prostate cancer. So this test that men are being encouraged to have at a certain age, the PSA test, that's a biomarker of prostate cancer. So a biomarker is any test that gives you an idea what the disease is. Okay. So the blood tests we're using are biomarkers for fungal infections. And the blood test, it picks up something specific about the fungal organism.
In your blood? In
the blood, yes, but it can also be done on other sites.
Oh.
So often people have fungal infections in the lung, and one of the tests people have, if that's suspected, is they have a telescope put through the nose down into the lung.
Oh, really?
Yeah.
Oh, and, I just thought it was a blood test.
And suck fluid out the lung, and then you can test the fluid for the presence of fungal infection or other things.
Oh, God.
So again, in BioDrive, we're trying to reduce the need for that because it is unpleasant.
Yeah, it doesn't sound very nice, does it?
Oh, and you're hoping that these tests will pick it up earlier?
Yeah, that's right, and remove the need for other more invasive or unpleasant tests.
Oh, right, okay.
So why is it that you're focusing on leukemia rather than sort of all cancers?
So there's something specific about acute leukemias. The therapy we have to give is so intensive and it weakens the immune system to such an extent that these organisms like fungi can cause a problem. So they're often called opportunistic infections, in that they're infections that take the opportunity of someone with a weakened immune system. But the principle could apply to other scenarios. Other chemotherapies are used to treat a whole host of other cancers, but the blood cancers need particularly intensive therapy.
So they particularly weaken the immune system, which makes you particularly susceptible to these fungal infections.
That's right.
Right. Okay. So in leukemia patients, how common is the fungal infection?
So it's actually hard to know because they're so hard to diagnose. Very often people will say, "Oh, well, there's a probable infection," but there's a high degree of uncertainty around that, and the estimates vary from maybe 1 in 20 up to sort of 1 in 4 or 5, and that just reflects the uncertainty about how these are diagnosed. So one of the things we hope BioDrive will find is that we'll know really what the true how common these things are, because the people are being very closely monitored. It's all being recorded. So we hope we'll get some useful information about just how common this problem is. But in terms of how often these medicines are used, so people like myself are one of the main users of antifungal medicines. And the NHS spends tens of millions of pounds a year on these drugs, which again is fine, but it's likely that a lot of that is probably not needed.
Yeah.
So it's for the people we look after, it's a major problem, and for the NHS, it's a major problem as well.
Yeah. Oh wow! So in your BioDrive project, then I guess the thing you're trying to test is blood tests special biomarker blood tests.
Yeah.
To find out if you have the fungal infection.
Yeah.
And then we'll give you the antifungals.
Correct.
Rather than just using preventative antifungal medication.
That's right. Yeah, it's trying to be cleverer about how we sort of diagnose and treat fungal infections.
Yeah.
But it is a complex area, and we have run into problems around that Lydia can probably tell you more about.
We'll bring her in now, I think. We've not asked her any questions.
I'm not a clinician, so I'm really glad that you're here, David. But yes, we have run into challenges. Obviously, all research projects have their challenges. A lot of them are very similar between projects, but some unique ones on BioDrive were things like turnaround times, so the time it took to take the blood test, the biomarker blood tests, and the time it takes to send them to the lab. Some hospitals perform the tests at that same hospital. Some of them send them away to an external lab, which can often be many hundreds of miles away. There's different methods of how these samples are transported. Some are very quick. Some we were finding could take a couple of weeks, which obviously when you're trying to detect fungal infections quickly
is not enough, is it?
And that was obviously making haematologists not comfortable, understandably, to withhold antifungals and wait for those biomarker tests. So we've done a lot of work with different sites, with regional microbiology laboratories around the UK to try and find ways to potentially reduce those turnaround times, which has largely been successful. Because it is a pragmatic trial, so we say we're not.
What does that mean?
So we're not changing the usual processes at the NHS hospital site. And what I mean by that is, so we weren't putting in a whole new pathway to get these biomarker tests. We were saying use your existing pathways, and if haematologists or any of the treating team wanted to, if they felt unsure or felt a bit uncomfortable about withholding antifungal prophylaxis for any reason, we said that's fine. Do what you feel comfortable with as the treating clinicians. We will just collect the data and analyze it.
Yeah.
And it's all important information, but essentially it means that they could do what they wanted to a degree. I don't know if you...
So we, as you say, the trial was designed to align with current practice, because the idea is at the end of the trial, whatever we find, we'd want those results to be able to be implemented straight away in the NHS. We could have designed a trial that used a fancy experimental blood test that was done in one super sophisticated lab somewhere in the country. But if that test is not routinely available, then at the end of it is pointless, because you've done something and all you've done is prove that using a fancy test that can't be routinely done is useful.
Yeah.
So the trial again has been designed such that whatever the findings are can be implemented straight away.
Yeah.
So if we find that actually the approach using these sensitive blood tests is not helpful, that's fine. Then we know that, and then we can disseminate that, and people can say, okay, we won't do that then.
Yeah.
And then conversely, if we find that using these tests actually is helpful and does reduce the use of these medicines and does improve quality of life, then it can be, everyone can say, oh, okay, fine, and then switch straight away. So the phrase pragmatic links into that a bit, something that the trial can actually then be
used straight away.
Yeah, that's right. Yeah.
So it's adapting something so you can use it in the real world, isn't it? Really.
Yeah.
Otherwise, you can test things.
Oh yeah, you do all sorts.
You can do all sorts of testing, and then you
Yeah.
try and roll it out and bring it to the NHS, and they go, nope.
Yeah, you want it to be able to work in the real world.
Yeah.
Yeah.
And a lot of research does. There's I can't remember the phrase of it now. There is a term, isn't there, for the gap between doing research and actually implementing it, and there is it's like a chasm between doing the research, finding out what you find, and then trying to implement it in real practice.
Yeah.
Yeah. It takes a while, doesn't it?
Definitely. There are definitely challenges in the chasm.
So when are you planning on finishing? I'm jumping ahead here, but how long is this going for?
So we are a little behind in our recruitment for various reasons. So we were basically the minute we have approval to recruit until at least the end of May 2026. We expect it to continue past that, but we're in current discussions with the funder to sort of present exactly, how much time we need and how prove that we can get where we need to be. Because we obviously want to be able to complete the research and be able to add to the research to the literature.
Yeah.
And I think we can. We're just waiting at the minute.
And there's no one else in the world doing something like this as well. And there's only really the NHS is set up to answer these sort of questions. So I think we're confident we'll finish the trial and we're confident we'll get an answer, but it is going to take a bit more time.
Yeah.
They always do that, don't they?
Yeah.
They come across things that you don't envisage at the start. And
the process of doing clinical trials is not entirely straightforward.
That's probably a better way of putting it, isn't it?
Yeah. Well, speaking of clinical trials and trial design, so you're doing a randomized control trial, just to rewind a bit. So it is a randomized control trial, and you're looking at the clinical effectiveness and maybe the cost effectiveness as well, I assume?
That's right, yep.
Brilliant. So could you just talk me through the kind of design of the trial and how it works?
So we are recruiting patients. David, you might be recruiting people. We're not recruiting directly to you. I'm not recruiting patients. But yes, we have several hospitals open across the UK. They will be approaching patients about the trial, presented all the information about the trial, and hopefully give informed consent to join. Then they'll be randomised to one of the two treatment arms, so the biomarker arm that David's explained, or the usual practice. So that's kind of the randomised part of the trial.
So they're randomly put in those two groups. It's not a choice by anyone.
Yes,
it's just totally random, and that's very important, as we know in research.
Yes. So we don't obviously do that because we don't want to have biased results. The idea is by doing that, you will have equal spread of certain baseline characteristics that might have an impact on the outcome. So it should mean that at the end, any difference in effectiveness between the two arms, the treatment groups, the control versus the intervention, you should be able to say confidently that's because of the intervention and not because, say, there's more elderly people in one arm versus the other.
Yeah.
Is the idea.
It's well explained.
Yeah, that's why we love a randomized control trial, the gold standard of research.
Oh, yeah.
Trials.
There's a computer flipping a coin in York. That's what I tell my patients.
Yeah, that basically is what happened.
Yeah, it's got a little robot arm and it flicks the coin.
Oh, that'd be much
down.
more fun.
I wish that would be so much more fun, wouldn't
That would
it?
be much more fun than how it actually is done.
Yeah.
Is that not how it's done?
That is exactly how it's done. I will not burst the bubble.
No. It's, we don't have to burst bubbles. No, yeah, I think that's really good way of explaining it.
Yeah. And so half of your patients get your blood test and half get the usual care. And then how will you know if it works? Are you asking questionnaires or do you have kind of more blood test results?
So we have kind of two arms of data that we're collecting.
Yeah.
So there's patient-completed data. So like you say, that's questionnaires that the participants will complete at different time points during the trial. So they'll do one at baseline before they are entered into the trial. And then they do one at 3 months, 6 months, and 12 months. I should say this is a sort of 12-month follow-up period from when they join the trial. And then we also have the data that the hospital will complete from patient notes, which will feed into this. So it's a slightly odd trial in that we have two sort of primary outcomes that are being assessed. Normally, there's only one. So we've got our key bit of data that we will be looking at. The most important is we call them primary outcomes. And ours is going to be at 12 months antifungal exposure. So it's
what does that mean?
What is that?
So it's defined as receiving more than 3 consecutive whole days of antifungal medication. So we'll be looking at how many patients have that between each group.
I see. So how many times they've had that you've had to give the medication for antifungal?
Because we want to see if the intervention is reducing the amount of antifungals that are being given. And then the second primary endpoint that we're looking at is patient reported. So we're looking at their quality of life, self-reported quality of life.
Yeah.
So those are the questionnaires that ask you about
exactly.
So you're enjoying your life, basically.
Yeah, basically.
Essentially, trying to think what all the domains are in the questionnaire. So there's like pain.
Domains? What do you mean by domains?
So there's basically just different questions within that. So there's one about their pain on that day. There's one about how well they're coping with self-care, so like washing and dressing themselves. Their mental health, so there's a question on depression and anxiety.
Oh, right.
It's a well-known questionnaire that's asked a lot of trials, isn't it, about quality of life. And it's been a validated questionnaire that's been used for a lot of years now. So, so that's why.
So you're looking at basically the number of infections, fungal infections, and
that as well. So Lydia's described what's called primary endpoints, but there's lots of other things. We want to make sure that what we're doing is safe and we're not making anything worse for anybody.
Oh, definitely.
So we look at the number of infections, as you say, and other outcomes related to the blood cancer. So all the sort of things that you would want to look at to be sure that what we're doing is safe is being looked at carefully.
Yeah. Brilliant. So you're looking at the cost effectiveness as well. Can you tell me a bit about that side of things?
Yeah.
You probably know more about
or we can get the healthy economist in here.
So we, as well as obviously looking at the impact of this intervention on the patients and the clinical effectiveness, it's also important to look at how the costs might differ between the two arms, because that's something that is considered by the NHS, and it is an important element. So we will be doing, I will not be doing it, but a very expert health economist will be doing analysis of the hospital data and working out the difference in cost effectiveness between the two.
It is important, isn't it? Because it saves the NHS, if I can say it properly, it saves the NHS money. it's a good thing.
Yeah, and it's not primarily about money saving,
Mm-hmm.
but it's definitely about using the NHS's resources, which comes from taxpayers.
Yeah,
it's about using that in a sensible way. And if people need to have lots of expensive medicines for this, that, and the other, that's fine. But we want to make sure that we're using them in a responsible and correct way, and not subjecting people to medicines that they don't need. And these medicines do have side effects. And not sort of generating resistant bugs that can come back and cause more problems in the future.
Yeah.
So that's the primary thing.
Yeah. Brilliant. It sounds like a really, really great project, really interesting.
Oh, thank you.
And I don't think we've had a medicine project in the research room yet, have we? So I think
No, we haven't,
our first medicine one. And been very, very interesting. So we've got just a bit of fun now. You might have noticed we have a hat here in the studio.
Very nice hat.
So we've got some little random research questions that we're going to ask you. So don't worry, none of them are hard. Well, actually, some of them are a bit hard, but none of them are scary. They're all just fun.
Go on then. Can we ask you one? Do we does it cut both ways?
Absolutely
you
not.
That's a different answer from I said you can if you want.
Yes.
Yeah. I'm
maybe.
Very amenable today.
If you could have any superpower to help with your research, what would it be?
I would like to have the superpower of super persuasion
to
convince some of my colleagues who some people sort of waver on whether they want to open this trial or other trials. So I'd like to have the power of super persuasion such that every one of my colleagues around the country I spoke to would go, yes, we would love to open it.
That's a great one.
And we will recruit 100 people per site.
Oh, wouldn't that be nice?
Super persuading.
Yeah,
super persuasion. That's what I would like to have.
What would I have? Maybe, Bernard's watch where he stops time, and I'd quite like that.
Oh, yeah.
I feel like there's often so much to do and you could just
stop time and then you have time to do some more work.
Yeah, that's a bit depressing.
No. I think I prefer the super persuasion one.
Yeah, so you can stop time and then have loads and loads of fun.
Yeah, I do it use it for good and evil. There's options.
What's the evil?
I don't know. Rob a bank or something. Yeah, don't leave that in.
Perfect.
No.
Just move someone's pen slightly and then just mess
just
with
to mess with them. Ooh, evil over there.
Oh, dear. What is your favourite part of your research?
The favourite part of my research is that during the design of the research and the process of getting it going, I've had lots and lots and lots of meetings with my colleagues around the country. So one of the few good things to come out of COVID was the move to sort of meeting on Teams and one of the good things about that is you can meet and talk to people much more easily. So I've had lots of very, very pleasant meetings with people like Lydia and also colleagues of mine around the country talking about the trial and the objectives and so meeting lots of people who name I knew but had never met in person. So all the people I've met and everyone is uniformly lovely.
Yeah, it sounds like a very nice collaborative team.
Yeah, it is, and that's the only way. In medicine, that's the only way that you get things done. Really, it's never just sort of one person or one team in a room or an office. It's everybody working together for the common objective of making things better for patients.
Lydia?
Oh, very boringly, much the same. Yeah, working with so many different people. I guess in the trials unit as well, we've got so many different branches of people that need to be involved in a trial who we get to talk to. So you've got the statisticians, health economists. I'm going to miss someone now and it's going to be really bad.
It doesn't matter. I don't think we're ticking them off.
Everyone, I love you all.
Don't cry at the end of it.
And people like David and Gavin. And it obviously helps massively when everyone is lovely and all want the same thing. And it is nice to think that the research will hopefully add to the literature and have an impact,
make a difference to people's lives.
Yeah,
that's right. Yeah, the research isn't an end in itself. The end is trying to improve things for the people we all look after. So.
Yeah, I think that's always nice to remember. Kind of that's why we do it, really, isn't it? It's to help people really improve their lives.
Yeah. Absolutely.
And people are the centre of what we do, really. That's probably why we like being involved with people.
Yeah. Oh, lovely answers.
That's really nice.
What's one thing that you wish you had more time to spend on?
Does this have to be trial related?
No, anything.
No, it doesn't have to be.
Craft. I'd like to learn how to knit, but I don't have the patience. So we'll see. But if I had that watch, you know, that's
there you could stop time and you could do so much knitting.
You don't just stop time.
Oh, I'm so sad.
Is that a watch that can turn back time as well? Or was that Harry Potter I'm getting muddled up with?
Oh, yeah, that would be good too. Yeah.
Yeah, okay.
Just spending time with my family.
Oh, making pasta.
Making pasta, yeah.
Oh,
yeah.
Oh, I love it.
Oh, one thing you wish you knew earlier.
In relation to our research, or
I
just
would think so. Not in life.
Not in life.
We could be here ages. No, just what one thing you wish you knew earlier before you, I suppose, embarked on the research.
I just think how difficult it is to get research going in the NHS and the barriers you'd overcome. We have to overcome. So we'd have still done it, but I think I'd like to have had more insight as to the challenges that you can meet running research in the health service.
Yeah,
similar from me. And I'm sure lots of people have said this, but it has definitely changed since COVID.
For better, for worse?
Both, really. But I think it's the setting up of hospitals since COVID has been a little bit slower. And obviously this study was designed and started kind of 2020.
Oh, just as COVID.
Yeah.
Oh, dear.
So I guess I don't know how you'd know that. You didn't know that the pandemic was coming.
No.
But yeah, just if it was possible to kind of predict that and be able to sort of start things earlier, sort of know what was going to happen.
You'd like to know about the global pandemic.
Yes, please.
I can relate.
Pandemic watch. We can organise that. Pandemic watch.
We'll have a go.
We have spring watch, don't we?
Oh, it's very
Autumn
similar,
watch.
I think. Yeah, must be. Yeah.
No.
Right, we'll do one more. Oh, okay, this is a would you rather. Would you rather have to present your research findings entirely in rhyme or using only interpretive dance?
Oh, is it on Zoom or in person?
At a massive conference.
I'm going to say dance.
Ooh.
But I'd have some sort of like mascot outfit on, so I felt less sort of
so they couldn't see you.
So I don't know what, maybe a giant chicken or something.
Oh, wow, I like it.
That'd be good,
Or a giant blood cell.
Yeah, you should be a giant blood cell.
If I could get my teenage children into the same room, I'd do it by interpretive dance, just to
embarrass
just to mess
them.
with them. Yeah.
I think it's a good way of sort of presenting your research, actually.
Yeah, I think
Get
I'd do
people's
it in
attention.
rhyme though. I think it'd be quite fun
I can't rhyme.
to make a song out of it. Although it probably wouldn't be a very good one.
I think trying to find a more interesting way of presenting research at these meetings would certainly be a good thing. So
I think so
yeah.
too. I would definitely go
Yeah.
if they said we're going to have a BioDrive interpretive dance for
Can I
you.
suggest a chicken costume?
Yeah, in a chicken costume.
Think
I'd
about
definitely
it
be
for when you
there.
have to present your research.
Watch this space.
that's right. I'm making notes.
Yeah, okay, write that one down. Top tip. Oh, well, brilliant. Thank you so much for coming in to talk to us in the research room. That was really, really interesting. And we'll put all the information in the show notes so people can find your website if they want to get involved or find out how it's going.
Yes, thank you very much. It's been really good.
No, thank you.
Thank you. Thanks for asking
Thank
us.
you very much.